You know, Greg and Keith, caring for people at its heart is wonderful. It's wonderful. It's such a inspiring thing to walk alongside someone who's suffering and try to be useful. And that's what doctors want to be doing. The more we can get technology that works and gets out of the way of walking alongside our patient, the better medicine's going to be. And I love caring for people. So the idea that we could restore what the profession should be in terms of the joy of caring for people, that's the heart. That's the heart of it. And we can do it.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Greg Malkery, and joining me is my co-host Keith Washington. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Well, our guest speaker is Dr. Jessica Schlicher, the Chief Medical Officer for Virtual Care and Digital Health at Providence Health. Jessica's played a pivotal role in developing Providence's multi-specialty virtual hospital with the use of emerging technologies. Jessica, welcome to our webinar. Would you like to start by telling us a little bit about your background?
Sure. Thanks so much, Greg and Keith, and thanks for having me. So I'm a family doctor. I've been in practice about 15 years. And a couple other things. I was leading a free clinic in a rural community for about 7 years on a volunteer basis. I have the great honor of having worked in clinical logistics, hospital operations, and also on some of the core business problems that hospital systems are really experiencing in terms of physician staffing and how to leverage expertise across geographies when we can't hire enough to really cover that. There is no greater impact on health than where the patient is actually physically located. If you look across the United States, access as well as health outcomes is very heavily impacted by place. And the location where the patient is located really shouldn't be the reason why they're not getting excellent care. So that's why I'm so excited to be at Providence, where we have a commitment to spreading our expertise so that people have equal access regardless of where they live.
Great. Thank you, Jessica. Keith, do you have any opening remarks for today?
Yeah, Greg, just to remind our audience about Beyond the Blueprint, we like to talk about systematic design that pushes the boundaries of innovation in healthcare in a cost-effective way. So today we can focus on the role of technology to simplify clinical complexity, to enable smarter decision-making, drive better patient outcomes. And I think this conversation is going to be a step forward in how we can transform care delivery with technology that's designed by clinicians for clinicians.
Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible: Storage Systems and Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. So why don't we dive into this? Jessica, how does systematic design influence your approach to virtual care at Providence Health?
Mm-hmm. Well, we say human-centered design, right? Which I think is perhaps what you're suggesting. We always start with what the person needing care actually needs. And then we look at what the physician and clinician providing the care needs in order to meet that clinical need. So, for example, when we look at our teleneurology, we have a service line that provides emergent stroke and other neurology emergency care across 93 hospitals every day with a remote approach using just 6 neurologists. And that's possible because each of those hospitals may only have one of those emergencies every day or two. So by leveraging technology, we can bring you a person who only cares for patients with stroke to the remotest part of Alaska or the remotest part of Texas with an average response time of 3 minutes. So we think about what is the heart of what the patient actually needs? How quickly do they need it? And what's the geographic scope? And the bottom line is we have an enormous shortage of physicians, and it's not economically feasible to staff every specialty at every site across the country. It's not possible. So really the options are you can virtualize the best expert, or you can not have care. And at Providence, we've chosen the first approach, which is to have a multi-specialty hospital so that wherever you're located in the Providence footprint, or amongst the 50 plus hospitals we serve that are not Providence, you can see a psychiatrist, you can see a stroke specialist, you can see an infectious disease doctor, you can see a hospitalist who specializes in your condition in the middle of the night within 3 or 4 minutes. And you can see an intensive care doctor in a remote place where normally they wouldn't have any intensive care physicians at all. So we've really looked at the patient need, and that is that's what we design everything around that. But the other problem is you have to design to make the job doable for the clinician. We work across multiple EMRs. We have a portal that captures all of the correct data points so that it's easy to do the right thing every single time for every patient. And you have to design around the workflow because it has to get faster, and every year we have to be more efficient. So we measure all of those things. And it's really important too that we have physician leaders who actually do the work. They actually see patients, and every single one of us, including me, still sees patients in a clinic or in a hospital so that we kind of know how the work actually gets done. And I think that's the heart of it.
Great. Thank you, Jessica. As healthcare shifts to patient-centered care, clinicians often struggle with access to real-time accurate information. Could you introduce MedPearl to our audience? A company which, by the way, I believe was incubated at Providence Health's Digital Innovation Center.
Sure. An average patient chart is about the size of the book Moby Dick. Between 50 and 500,000 pieces of information. The average patient coming into a primary care doctor's office has 4 concerns. And if we were to do the evidence-based care on every patient we see in a day, the American Academy of Family Physicians says it would take 27 hours a day. How are we going to ingest what's in the chart in a way that helps us deeply understand the patient? And how are we going to understand those 4 complaints? And then how are we going to understand the medical knowledge that we need to apply to that patient context? And how are we going to do it all within the space of, say, 20 minutes? That seems kind of like unicorns. Like, yeah, that's impossible. But that's what doctors are doing every single day, figuring out what is the next best action for this patient. And no surprise, because of that, a primary care doctor like me might manage 1 or 2 of those complaints, but we might refer the other ones to a specialist. And some of those referrals, if I had more time or more actionable clinical information and understanding of that patient's chart and that clinical condition, they actually wouldn't need to go to the specialist sometimes. How do we algorithmatize the brain of the specialist and then make it accessible at the point of care? So here's an example. I was doing a 12-hour shift in urgent care, my 43rd patient of the day. I'd gone to sleep on a ferry, and when he woke up, he couldn't hear out of one ear. This was really alarming to him. He's a police officer, and if this persisted, he would have lost his job. So he came in. I took a look at him. My brain at this point is exhausted. Okay? Also, I'm getting older. I'm 45 now, Greg. It's not the same as when I was younger. Okay? So my brain's exhausted. He has an emergency that I've never seen before. And I have just a few minutes to figure out what to do for him. Normally, I would go to a 57-page PDF document and frantically search it for what to do for acute unilateral hearing loss. And I'd probably eventually find the answer, but I might miss it. But when I looked at MedPearl, I'm in the EMR and I click on MedPearl, and literally in 3 clicks, it said, here's what this condition is called. Here's what you need to do. He needs to see the specialist within 3 days. So I told him, okay, here's what we're going to do. We're going to start you on this medication. Tomorrow morning at 8:30 a.m., you and I are going to talk. And we're not going to get off the phone until you have an appointment. And you're going to get seen tomorrow. You're not going to work tomorrow. We're getting this done. The patient got into the ENT specialist, got the treatment he needed, and texted me to say that specialist said it was the first time in his 20-year career he had seen a patient quickly enough to solve the problem and prevent permanent hearing loss. Why? Because in my practice, I don't have that little pearl of information that I need to know what to call it and how quickly to insist that the patient be seen. And across all diagnoses and all of medicine, the problem is the same. What do I do? Because the patient's in front of me. What medicine do I do? What specialist do they need and within what time frame? So MedPearl has over 1,000 topics with probably 10 times that many diagnoses saying exactly what to do and whether or not they need a specialist and how to insist on that. It's really exciting to me because it made me feel like a superhero. And here I am with a brain that's like oatmeal at that point, perimenopausal, let's be honest, with a patient who has a condition that I've never seen before, and it allowed me to do the right thing for that patient. And there is nothing more engaging to a physician than saying, you're going to be able to provide that subspecialty care right now, and it's going to take you 2 minutes or less and 4 clicks, and we've designed it around the way your brain actually thinks and the way patients actually present. So when you're in Pearl, and I get excited about this, I have the patient's chart open. Pearl creates an abstract of everything in the chart. Here's everything you need to know from the Moby Dick size chart that's applicable to this patient context. And here's the knowledge from the subspecialist all in one place, algorithmatized so that I can easily see the right thing to do. And it's really fun. I teach residents, and another example would be people come in, and it's really common that people are struggling with addiction, right? But the comfort level of clinicians varies widely. For many years, regular old doctors like me were told you're not able to prescribe Suboxone. You can't detox people from opiates. It's not safe. Your license doesn't cover it. Well, now the world has changed. Now we're supposed to, as a medical community, suddenly become competent at prescribing a medication that for years we were told was unsafe, right? So in MedPearl, you see the patient context, you see the up-to-date medical knowledge, and I can click through and it tells me exactly how to do that. So I can upskill myself or my residents in a skill like prescribing Suboxone in about 5 minutes. These are the things you need to know. These are the emergencies you need to look for. Here's the data from the patient's chart and the best medical knowledge. Here it is in one place. See, previously, before MedPearl, we were all kind of trying to do a janky version of this. We all had smart phrases. We all had checklists. We all had little pieces of paper. We're trying to hold on to dosing of medications that have changed. If you look at a doctor's desk, it's like an explosion of Post-it notes, essentially, of like we're trying to do the right thing. But MedPearl curates all of that information into one place. And the other really uniquely thing that's cool is that MedPearl is a no-code environment. So if I say, hey, this COVID recommendation has changed, I can put in feedback and our team updates it today and it's live across 12,000 clinicians at Providence. It's not the normal IT approach, which is like submit a ticket and then get a year older and then kind of wait. And maybe at some point, the medical knowledge will be updated. I mean, I've worked at places where it took 3 years to get the correct COVID PCR test, even in a smart phrase, even in a quick button, right? So if you think about what healthcare needs to become, we need to become a lot more like aerospace, right? Where like when there's a mistake, within just a few months, every pilot on Earth knows, don't make this mistake again. You know, Atul Gawande checklist manifesto, that's what MedPearl can do. And it's such a powerful source of joy and happiness when we're practicing in that environment where it should take 27 hours and each patient has 4 complaints. It actually allows me to do the right thing, for God's sake, for people. And that's why we're here to begin with. So that's why I'm excited about it. And I should let you ask your next question because, as you can tell.
Awesome. What Can you give us some more examples of where MedPearl has been deployed either within Providence Health or maybe some other examples? Like where are we in your journey right now? I know that you guys have been incubated, but give us an idea of where it is today and where you guys are going.
Sure. So today we are live in 3 other health systems. We also have a partnership with a very large commercial company. I'm not able to share the details of those, but essentially we are outside of Providence live. We have about 4,000 monthly active users. We've had 300,000 incidents of MedPearl being used at the point of care with a patient. So we're really excited about that. And we're really just getting started. So MedPearl at this moment still sits within Providence, but will be commercialized in early 2025 as well. And I've told the founder, Dr. Evie Cunningham was the founder, and I've told her that although I will remain the CMO of virtual care at Providence, I will take any role, including cleaning toilets at that place, to keep contributing to it because I think it's really, really important. And we have a team of people we have about 15 doctors who are actively writing and curating and making sure that the physician brain continues to be algorithmatized so that this source of joy really remains and spreads across the country. That's what we hope.
Awesome. Can you explain a little bit of how AI is transforming clinical decision support and its impact on healthcare? Maybe kind of open up the hood a little bit and tell us the significance of the AI component.
Yeah, so we're very bullish on AI. We do stick with the best practices in terms of any piece of information that is going to drive a clinical decision that impacts someone's life is confirmed to its primary source. That's extremely important. So, for example, AI is very good at summarization, and it's also very good at comparing last year's ADA guideline to this year's diabetes guideline. It's 300 pages, by the way. What's changed? It's very good at that. But when it suggests something, it requires a human. We have some tooling that we use where we say, okay, here are the changes, right? I can hover over and it'll say here's the primary source and where that was explained. Because the human brain still needs to check that that's actually correct. That's extremely important. We do require, in medicine, it's really a 6 Sigma standard of care. There's not tolerance for errors, and we don't tolerate it in our platform. So any information that is going to drive a patient decision is going to be confirmed to a primary source. But it does make us much faster. We've tried, I personally have been diving very deep into all of the different engines out there. I have several favorites, but I think the speed at which we can find new insights is really exciting. For example, until recently, most of the medical research was done on a very homogeneous group of patients, usually male, usually Caucasian, usually American. Now, every single day, we're discovering that, hey, for this condition, actually with this genetic variant, you want to treat it a little bit differently. We have to find all of those scientifically based health equity insights and weave them throughout MedPearl. So we're doing that. We're using AI to find the newest studies, some that may not be in the mainstream medical journals, and vet those. AI can be used very powerfully to find the things that should be on that checklist. And then
I do
MedPearl
remember
enables
you
them to be
describing to
everywhere.
me as the head of content. I think that was your title, right?
Yeah.
You showed me some of the graphs, the complexity of some of the graphs, and it was enough to make your head spin. So when you guys are developing stuff for OBGYN, you're getting industry thought leaders or experts in the field who are developing these protocols.
Right. So if you imagine, take a 20-year veteran OBGYN who's cared for 20,000 patients, delivered 20,000 babies, right? 10 high schools worth of babies. And all of the struggle and all of the learning and potentially some of the things they would have liked to improve. And you take that brain and you align it with an intelligent AI that can show you the most recent studies, the most frequently missed diagnoses, all of that. And you turn all of that into a simple algorithm at the point of care and then democratize it across all physicians. That's really cool. That's what we're doing.
Wow. Now, in implementing these new technology, it often comes with challenges. What obstacles have you encountered when rolling out MedPearl at scale? Or, well, right now you have 4,000 active users, right? But as you start to deploy this in greater numbers, what are some of the issues that you're anticipating encountering?
Yeah, it's really interesting because when I talk to technologists, they usually say, how in the world did you get doctors to adopt this? Right? But what we like to say, we've had over 300 doctors work on it, like create it. We've had to start over a bunch of times. We've designed it around the clinical workflow. So what we like to say is if the doctor gives birth to the baby, then you don't have to force them to adopt it because they gave birth to it, right? So first of all, that was really the key to the initial scaling and success. We initially, this is one of our jokes, we had this plan for deploying across Providence. It was like by region and by clinic and by, phased, logical, asking permission. Well, what happened was the regions that didn't have it yet rolled themselves out. It spread virally across Providence as well because this is like, for example, when I was teaching at the residency like 6 months ago, a doctor who wasn't using it yet looked over my shoulder and saw me using it and said, "What is that? What is that? And how do I get it?" And I'm like, "Oh, it's right here. It's a button and it's right here at the top in the EHR." So I think first of all, the brilliance of it is how it was created. And that was created by Dr. Cunningham before I was even here. The brilliance of it was that there are also like hundreds and hundreds of hours of sitting in the technologist sitting with the physician in the clinic watching how they do their work. That was really important too. I think there's some interesting barriers. First of all, how we use AI is really, really important. It's absolutely imperative that we use it for scale and for speed. But we have to continue to earn the trust of our clinical users by being very transparent about how AI is used and that we confirm to primary sources. Because doctors who've been around once in a while don't care for people based on a Google search. So we have to continue to articulate our strategy in a clear way. And we have to continue to be Six Sigma reliable. I think that's really important. We have to keep, I think a challenge operationally for us is keeping the content updated. So we do have a dedicated team that does that. For example, last 3 or 4 years, the treatment of COVID has changed and been updated, frequently. So we have an infectious disease doctor who's most of his time is like making sure that what we have live in Pearl is correct. So we have to scale to be able to maintain those 1,000 topics. We have to use AI, but we also have to be very purposeful about communicating that we're dead serious about it being right. I think we'll be able to do that. I don't see it as really a problem so much as an opportunity. But we're getting lots of interest. We have a robust pipeline. I'm excited for any problems or barriers we get, Greg, because honestly, getting doctors to do anything is difficult. And when you give them something that actually restores the joy of practice, it gets to be really powerful.
So you're not seeing any resistance at all. You're seeing exuberance and joy.
No, we're seeing people say, and I want this in there too, right? So we did not, when we started out, this was an ambulatory tool. It was going to be primary care focused. It was going to be about optimizing referrals. And that's still true. And we can prove financially that that's been very good for Providence. But the hospitalists and the 130 doctor team that I lead that does the acute telemedicine, they're like, hold on, we also want our guidelines put in there, and we want all of our SharePoint documents in there, and we want all this stuff algorithmatized. So the demand is actually, we've had to adjust our strategy a little bit because the inpatient doctors, the emergency care doctors, the pediatricians, they all want their stuff in there. And
Well,
what's really interesting,
you raise an interesting point about the use of telehealth, right? Not only with the doctor at the mothership, but also the ones that are part of the feeder network, right? Where both sides are using it. Have you are you seeing any particular traction in that area alone? Because you did bring up the ED example earlier on.
Yeah, exactly. So actually I have a great example of that. The head of teleneurology for us, his name is Dr. Archit Bhatt. He's an excellent neurologist. He designed the MedPearl that his team now uses. And what it is it actually pulls a neurologist looking at a patient chart. They're affectionately known among doctors as the nerdiest nerds. They want to look at probably 100 data points in that chart. Have they ever had this type of imaging? Have they ever had this type of blood work? That normally might take them 20 minutes or more just to kind of honey badger through the chart to find that data. And it's obviously when you're doing it manually, also like there's an opportunity to miss things. So Dr. Bott designed this data finder where essentially when he's in a patient chart, he clicks on Pearl and it curates everything that he wants to see into one pane of glass. The very first time he used this, he was seeing a patient in consultation in the hospital who had wrist drop. So she had weakness of the muscles that bring her hands up, right? She'd been in the hospital for a week and nobody could figure it out. They were ordering imaging and more labs, and it was like, what in the world is going on? He went to MedPearl, one click, all the labs in one place. There was a severely low B12 level, which had been missed. And low B12 is the first thing you think about, right? But again, we're combing through the Moby Dick size chart, trying to find the pieces of data to make these decisions. And it's just very, very difficult. And that's part of the reason why medical errors occur. And so this particular MedPearl designed by the user himself that he's now using with every single patient, which will prevent the errors. Same thing for psychiatry. So our virtual psychiatrists see patients across 8 states, 43 hospitals. And when they see a patient, they also have a data set. They need to see the drug screen. They need to see the brain imaging. They need to see, there's probably 50 things they need to look at. And normal workflows like, again, honey badger through the chart. But they designed for themselves a MedPearl, no code environment. They can do it themselves, right? Cool. So every time they have a patient chart open, they just click on MedPearl and it shows them every result they need to see. So you're hardwiring this experience and making it impossible to make a mistake. Less likely to make a
Sounds
mistake.
very positive. I love the idea of the physician satisfaction. That's unbelievable as well. And what about the measurable impacts as it relates to clinical outcomes or operational efficiency? Have you done a lot of ROI analysis and outcomes analysis to demonstrate its efficacy?
Yeah, so the great news is being incubated inside a health system over a 3-year period, we've been required to show a hard ROI, and that's one of the most fun things we've seen. We can show statistically significant improvement in the contribution margin of patients when the patient is sent from primary care to specialty care, that actually that patient is more likely to need surgery or procedural care. So we can actually conclusively show and prove that within Providence, number one. We also know that when I see a patient and I think, man, I probably need to refer them, 20% of the time, I end up not needing to refer them. But our clinics remain full with patients who really needed to get seen more quickly, right? So we can actually show positive financial impact, positive access impact. We also can show that there's a statistically significant improvement in the number of doctors prescribing Suboxone for opiate addiction. And if you imagine the core operational problem that health systems have when they're access constrained is you have a funnel, right? You have too many patients, they can't get through to the specialist, but there's a few patients in there who need surgery like tomorrow. It's an emergency. MedPearl can be shown to actually find those people and move them to the front of the line. So those are some of the things. We were published in September of 2024 in the New England Journal of Medicine with some of those results. And I can tell you that there was a rigorous process for us to get those metrics put out there. So we were very proud of those.
Oh, good. Okay. Looking ahead, where do you see MedPearl in the next 3 to 5 years? You've made a lot of progress, but as a visionary, where would you like to see this go?
Well, we would like it to be integrated into ambient technology. So more and more when doctors are seeing a patient in the room, they're not writing their note anymore, right? Ambient is transcribing that note. So our vision is that MedPearl will be integrated and able to say, okay, so for my hearing loss example, I open the chart, MedPearl, I would no longer have to ask MedPearl anything. It would tell me, hey, by the way, this patient has sudden unilateral hearing. Here's this algorithm you probably want to look at. Here's the data. So we want to show it to people without them having to ask. Yeah, it can be done. I mean, if you look at Abridge and Nuance and some of those things, they're actually getting better and better every year. And I think the core problems, that drive burnout are like, well, inbox is one, and then clinical documentation is the other. And Ambient is really helping with that. But the clinical documentation has to be united with both the clinical knowledge of what to do next, the best thing you can do next, and the chart abstraction. What from this chart do I actually need to look at? If you don't have those pieces, the Ambient is very cool, but it doesn't make sure you do the right thing.
Great. Jessica, I'm going to check in with Keith. Keith must have some questions he might want to ask.
So, this is really exciting. It is like what Greg was just saying. It almost sounds too good to be true, but it would be really exciting. I love the example you use, like the aviation industry and how that works. Because I mean, if you, like, say, if the lawyers ran the aviation industry, no one would ever get on a plane. There's just no way, right? All the potential risk, all the things that could go wrong. And so I love the idea that you guys are out there, like, trying to work as leaders in a transformational way, not necessarily violating any rules, but just pushing the boundary. I think that's so important. So I would say, do you feel like that can continue to build this momentum to, like, have, like, physicians are going to say, well, do you use MedPearl? And that's sort of a qualifier before they get involved. And I'm not trying to, let's say, promote your brand, just the idea, the methodology of what you guys are doing.
Well, I think every good doctor uses all of the resources they can get their hands on, and MedPearl is part of that toolkit for sure. I love that you mentioned lawyers. I happen to be married to a lawyer doctor, super nerd, and we were at a conference a few months ago, and one of the lawyers made the terrible mistake of asking me what I was working on over dinner. So obviously I pulled up MedPearl and started showing it to him. And I said, what is the thing that you paid the most for in a medical malpractice case last year? And he told me. And I opened Pearl and I said, let's look it up. The first line of MedPearl would have prevented that lawsuit. The first line. And he said, can I buy that? And I was, soon, my friend, you can buy it. The other interesting thing is he said that attorneys pay for experts to sort of decipher the case for them and even tell them, like, what it's about and, like, brief them on what the condition is and all of that. He's like, man, if I had this, it would save me so much time, because it would, like, in a plain language way, explain to me, like, here's this type of leukemia, here are the common treatments, here are the labs to do, here's when you go to a specialist, and it would give them a first look at what their expert might take, days or weeks to get back to them. So I do think that having a no-code tool that enables knowledge sharing in a way that is not annoying and that actually makes work easier is applicable across industries. Now, I'm not sure that our CEO would want me to say that, but I think the tool is very powerful across all specialties in medicine, and can also be powerful across any other environment where information sharing is difficult. I mean, you look up, if you've ever had a problem with your computer and you try to figure out how to fix it, it's like terrible. So I think the problem actually of algorithmatizing knowledge and then democratizing it probably exists in most industries that are not as advanced, as aerospace, for example.
Yeah. Well, and I think that it's just like you described, this idea of being a nerd. Okay, I think of that as being technical. And a lot of times, professions like being a physician gets very technical, or even being an attorney is very technical, or being a CPA is very technical. But running an organization is a whole different thing, because you have to, let's say, integrate all these functions in such a way. And then, let's say, when you have the tools, because I would echo back to you, I think every person, regardless of their profession, wants to do their best. They want to give it their best, right? It doesn't matter where you are in the organization, whether a physician or, even attorney, even though, people like to pick on the attorneys, that they're working hard. But one of the things about attorneys is the nature of their profession is not decision maker. That is not what they do, right? They highlight what can go wrong, and they try to help you anticipate what could go wrong and plan for that as a process. So, and it's super complicated, but I think of it more like the first time I ever used Uber, like what that felt like. Because what is Uber? Like, what is
Uh-huh.
that? Like, no one knows what this is.
Uh-huh.
And then all of a sudden
Uh-huh.
you're using it, and then just like overnight, everybody's using it. Like, and now it's like, who wouldn't use it? Like it's like no one thinks about, too many other ways. Like if I got to get around, if particularly if I'm in a city, but if I'm in the middle of nowhere, like you're saying, access to healthcare, you don't have access to Uber in every market. That's not always a thing. So I would just say it seems really encouraging what you're doing, and I think you've got the right spirit of going about it in a very positive way. And so I guess I would just ask you: are you, you said before, at the end of a long shift, you feel fatigue. Do you still get energized by this? Does this still seem like something, like you said, you'll even clean the toilets? Like, how do you transfer that to like a broader population of leaders that want to take that same approach?
I think everyone's already struggling with the problem. It wouldn't be a news to any doctor that it's hard to figure out what to do. I mean, it's hard to figure out what from this chart is relevant. How much time do I have to read it? How can I get the data that I need? I mean, literally, my workflow before MedPearl was to pull a paper towel off the wall and write in whatever pen I might have stolen from my nurse colleague pieces of data down on this paper towel to try to figure out, like, okay, this patient wants a GLP. What were their lipids and what other labs did I need to do? And what's the dose? And how do I? So, I mean, we're all struggling with it already. And so MedPearl kind of feels like you're doing a deadlift of a heavy weight, and MedPearl kind of like takes it off. That's what it feels like
Yeah,
when you're
well,
in the
and I guess
clinic.
maybe I'll ask my question a little better way to say, if people are coming to you and saying, well, it sounds too good to be true, therefore it must be. Like, what do you say?
Mm,
Or I guess,
yeah, I
how
tell
do you
them, yeah.
use it?
I tell
Right.
them that I realize, so this is usually how I open a talk to doctors. I want to be honest that you may experience technology as like a lot of promises, and then it's like being hoisted on you and it makes your life worse. If that's been your experience, I beg you for 5 minutes of your open mind and attention, because it's going to sound like unicorns and rainbows. And if you try it and it's not useful to you, fine. But please, I beg you to spend 5 minutes, because I actually this has made my life easier, and I think it could be a huge help to you. If after like, so that's what I tell them, and I think it's important to like kind of do that thought audit initially. But I've never had someone say to me, "Oh, no, I won't use that." No, never. I've had people say, "I have a suggestion, I have feedback." We've had more than 60,000 pieces of feedback put into MedPearl. And we had we had a nurse who said, "I can't believe you don't have this one topic." And it was very colorful, words you might hear in an emergency room, kind of email. And so I wrote the topic myself and wrote him back, and we were like, "Hey, you're totally right. We agree. It's live now. Please give us commentary." And this person was so shocked that someone actually received his feedback and actioned it like the next day. That's the level of service that we want to provide, because it's so different than what we normally get in our lives in terms of our technology, right? Um, I think too, like when you brought up the Uber example, what I feel when I use that is a deep respect for me as a customer. Like a real, you're going to tell me how long it takes and exactly what it costs. Thank God. That's exactly what we're doing, right? We have a 2-minute budget. So any algorithm that we have should take 2 minutes or less to read. And we measure that. We do not waste time with like, in 1942, the first person to describe this was Dr. blah, blah, blah. No, none of that. What do I do right now? Yeah. We have to stay true to the heart of that, I think.
Perfect. That's great. Okay, back to you, Greg.
Oh, great. Well, Jesse, I'd like to thank you for sharing your time, your insights and perspectives. I know it took us a little while to actually schedule this, I also want to thank our sponsors, Storage Systems and Simplify Medical, who made this conversation possible. Jessica, do you have any final thoughts you'd like to leave our audience with about MedPearl and how it's helping transform healthcare?
You know, Greg and Keith, caring for people at its heart is wonderful. It's wonderful. It's such a inspiring thing to walk alongside someone who's suffering and try to be useful. And that's what doctors want to be doing. The more we can get technology that works and gets out of the way of walking alongside our patient, the better medicine's going to be. And I love caring for people. So the idea that we could restore what the profession should be in terms of the joy of caring for people, that's the heart. That's the heart of it. And we can do it. So I guess that would be my final thought for you.
Great, thank you. Keith, do you have any final thoughts on today's session?
Yeah, very inspiring. So thank you so much for Jessica for joining and sharing your experience and your passion and your enthusiasm. I think it really underscores how transformative leadership potential of using technologies like AI in healthcare can really just be a tool for meaningful change. So it's just exciting to hear about MedPearl and what it represents for clinicians, and really that idea of bringing together clinicians and technology that's a little more, let's say, clinical focused, not just the technology for the sake of it. So I love the story. I love the progress you guys made. I think this could really be impactful. And I hope, to our listeners, I hope this inspires our listeners to really be bold and to move out and step out and be that transformational leader that their organization needs or that their community needs to really better serve people. I really appreciate your thoughtful words about that's what it's all about. I think that's what it's all about for all of us in whatever endeavor we choose, right? We're all kinds of ways that you're going to be able to help people. So really love this conversation. So I hope our listeners appreciate joining us on this journey, that a lot of what you talked about to me is very much about design, human-centered design, that it didn't just show up randomly. A lot of people worked really hard to get it to this stage. So I think that's inspiring. I hope it inspires others. And I hope you'll come back and join us in the future to keep the conversation going.
Thanks so much for having me. This is great. Greg knows where I am. Thanks, you guys.
Well, just a closing remark here. For audience members who are not familiar with us, Spyglass Consulting is a product and go-to-market advisory firm. We're focused on disruptive technologies and growth opportunities within the healthcare and life sciences industries. We proudly serve more than 250 leading entities, including technology companies, management consultancies, healthcare providers, and investment organizations. We've published more than 30 market research reports on a variety of informatics-related topics. To gain access to our library of pay research and to gain deeper insights into how technology is reshaping healthcare, I invite you to come visit our website at www.spyglass-consulting.com. With that, I think we have a wrap for today. And thank you very much, Jessica. And we look forward to speaking with you again.
Thank you.
Thank you so much. This is fun, you guys. Nice to meet you.
All right.
Nice to meet you, Keith.
Nice to meet you, Jessica.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.